It gives me great pleasure now to introduce our keynote speaker, Professor Ian Hicki. Professor Hicki is an internationally renowned researcher in clinical psychiatry, with particular reference to depression and other mood disorders, early intervention, use of new and emerging technologies, and suicide prevention. He holds a number of senior positions and works closely with the Department of Health, and some of his key areas have included being the former CEO of Beyond Blue, the National Depression Initiative, former Executive Director of the Brain and Mind Centre, formerly the BMRI, Federal Minister's Mental Health Expert Advisory Group member, and a member of the National Mental Health Commission to oversee enhanced accountability for mental health reform in Australia. So it gives me great pleasure to welcome Professor Ian Hicki to the stand. Thank you.
Thank you very much, David, and thanks to David and Magda for the opportunity really to speak to you this evening. What I'd like to do, having heard all those things you've just heard about all the services, is sort of slightly step back and give you something of the kind of overall setting of why we're in the situation, why you're hearing about a new range of services. Really what my view is from the National Mental Health Commission and my participation in the National Review of Services in 2014, which is partly responsible for where we are, and what the hope is really for the future. I'm very lucky in my life that I share my house with Arnie Joy Smith, who's an Indigenous person. And she has a great set of sayings. She's going home to Central Queensland this week, which is basically, would you guys get your act together? First of all, this week you can barely sort out who's an Australian and who isn't. She assures me there were many people here for many years, tens of thousands of years before, who were pretty sure they were Australian. The rest of us seem in a continual state of confusion about what it is that we're trying to achieve and how we fundamentally work with each other to actually respond to the populations that we serve. So I would like to actually start by recognising the traditional owners. And the traditional owners actually have something very important in mental health, which is central to many of our particular issues. In fact, it's a refusal to use the term mental health, and it is largely tied up with another piece of lingo, social and emotional well-being. But within that particular phrase is something really important, which is mental health is really about the social and emotional function of our community, as a community, not just as a series of individuals or disconnected services within that community. And a lot of the work that I've been involved in that particular area over the years, they have long said we're not going to set up individual standalone mental health services of any sort. The real issue is, can we create communities which, through all of their resources, in health, in education, in other sets of areas, support us all to live productive lives on an ongoing basis, no matter what our particular state of health actually is at that particular time. Now, it's interesting, actually, in the wider international discourse about mental health, and this is actually courtesy of the British government just prior to the financial crisis, a very interesting set of concepts got going about the mental wealth of nations, not the mental health of nations. And we've been lucky in recent times to convince Malcolm Turnbull to actually take this up as a way of describing what's going on here in Australia. Mental health's worth about 4% of GDP, done well, and you lose about 4% if you do it really badly. It's a big, not small, economic and social issue. And in most Western countries, we traditionally do it badly. That is, we sort of know it's important, we sort of talk about it as an important health issue, but we do not develop the style of services or the scale of services that actually support people to lead productive lives, should they encounter these sets of issues, short or long term. And so we've been lucky, and I make this particular comment because it really is the current Prime Minister, and current circumstances we have to refer to him as the current Prime Minister, who's really picked up the recommendations of the series of review that I'll talk about shortly to say, look, we have an opportunity here, we're at a point, an opportunity here where we really need to think about doing things differently if we want to end up, for those, and I apologise for you not being able to focus earlier on, about countries that have the cognitive, their citizens have the cognitive and emotional resources to actually thrive economically and socially. And at the heart of that is a little 5-word sentence which you won't be able to read, which actually says of all the things we know, early interventions are the key kind of perspective. Independent of the illness type, whatever language we use in a diagnostic type, if you fail to intervene early, the social and emotional consequences will be very large. And we don't, as yet, have the equivalent of immunisation. We don't really have primary prevention strategies for most of the major mental health problems. What we do know is you get in earlier at any time they occur or recur, the impact on a person's life will be considerably less. That's a summary of about 1,000 pages of evidence to set up that report. That is the key issue. And it applies not just in the first 6 weeks of life or the first 5 years of life or the first 15 years. It's at any stage of life that actually when things go wrong, when you go off the trajectory of building your mental capital, this is a marvellously economic term, and developing your full cognitive and emotional potential, you go off that track at any stage, or having achieved it at about the marvellous age of about 22, reached your capacity, and you start to lose it at any stage, you won't be functioning in that particular way. So it's an awareness right across the lifespan that there are opportunities to build that collectively, but at the individual level to intervene effectively as quickly as possible in the emergence of such issues. Now, it's a funny thing in a lot of health to have to discuss the importance of early intervention. I see there are a few slightly older doctors in the room, like myself, who might remember that we had trouble convincing people in the cancer world 30 years ago to come along early for a more effective treatment. If they were terrified of the treatment and its consequences, they were often reluctant to come along for care. It's still a dialogue that is very live and active in mental health. Most people who receive mental health care receive it late, when they already have considerable comorbidity and considerable disability. They do not receive it early in the course. Consequence, recovery is quite hard in a lot of those situations, and a lot has often been lost along the way. When you look at the economic costs, and it is largely, and has been for about a decade now, an economic discourse that we've had in Canberra. In fact, in all my various trips to Canberra, actually visiting Treasury and Finance is quite a lot of fun because they want to talk about the money and, geez, what a big issue that is, and could you mind doing something about it? The really desultory trips are to Woden to visit the health department, who say the money's already run out, we already spent it. New cancer drugs, new infectious diseases, kind of things, spend it on the hospitals, emergency surgical waiting lists. We're sorry we ran out of money before we got to you. Actually, the Finance and Treasury people go, can you help with this? The biggest costs, disability adjusted life years, living your life with disability, there's sort of twin peaks here. They actually peak in adolescence and in later life. Now, again, for those in the room, the good thing about the later life thing, which is determined by neurodegenerative diseases, is I've watched this curve over the last 20 years, and I sit here somewhere, is that curve keeps getting smaller and keeps moving that way. I hope to personally never catch up with it. And actually we're doing a lot in that phase, largely through better vascular disease, better lifestyle change, a whole lot of other things that are happening in that area, that's actually reducing total proportion. Although there are more people per se, people now living into their 80s and 90s actually in very good cognitive function and actually not nearly as disabled as the generation previously at ages 70 and 80. Where we've really struggled is in the child and youth kind of area. So if you look at what's going on in that area and people who go on to live their lives on welfare support, disability support, pensions, etc., is that is in fact the big cost, and the shape of that has not changed much at all in recent times. So we often say in our area, if you're middle-aged, go to work, we actually don't care about you. We're sitting with Finance and Treasury, we care about you if you're young or you're a teenager or you're in the ageing area, and we could do something differently and actually run systems differently. Now, in addition to the Prime Minister having great interest, we're quite lucky at the moment to actually have a Minister for Ageing, Ken Wyatt, who's not only fundamentally influenced by the Indigenous approach to community care, but actually wants to do aged care for mental health, not just for dementia, but for mental health quite differently, based on, of course, most people want to stay in their homes and receive effective care. And there is a twin peak of new onset depressive illnesses and other sets of issues which are not simply dementia associated with physical illness in later life. And actually to have Greg Hunt now actually say, and he goes around to a whole lot of doctor meetings and other meetings and say, one of my most important issues is mental health. People go, what? He goes, no, seriously. His mother had a serious mental health problem. He's seen how hopeless services can be and the impact as a child in that particular situation on his family, his life, of just being stuck in one of those bits of the healthcare system that doesn't work. No matter how much resources you've got or who you are, it just doesn't work a lot of the time when faced with significant ongoing problems. So we're quite lucky at the moment to have a Prime Minister, a Minister for Ageing, and a Minister for Mental Health who are actually seriously involved in saying, okay, there are three big areas. Now, the reason you've heard so much about youth services tonight is that's probably the one in which we have the most enthusiasm in Australia for doing things differently. And much through the work of Pat McGorry and his colleagues in the Australian of the Year in 2010 and innovations in Australia, we have developed services that don't exist really anywhere else in the world, the headspace type frameworks for saying we need new service models. I personally spent a lot of the 1990s in GP-based education and other sets of enhanced mental health care through GP and primary care-based services, which largely touched people over the age of 25 and under the age of 75. It was good if you were in the middle. And that better access and better outcomes sort of stuff that we've had has largely been for benefit of those in the middle. We've got to do things differently. Now, we actually have largely a national agreement which I'll dwell on about some of the lessons we're learning about that and some of what you're seeing rolled out this evening, we've got to do better in the youth area. We actually still have no agreement at all about what to do in the child area, which remains a major ongoing set of problems. And there is a visiting of how should services look, not just for cognitive impairment, but for mental health problems as you age and remain in your own home. Now, this is where the PHNs become really, really important. They're supposed to be looking at this thing from a population point of view. How does it look here in northern Sydney? What's it look like? Where are the gaps in the particular services? And where are the opportunities for doing it differently on an ongoing basis? Now, the youth area is driven by the epidemiology. These peaks of onset of all the major mental health problems. Don't worry what they're called. Don't worry whether we call it this eating disorder, that mood disorder, that psychotic disorder, that's personality disorder. Forget it. It's just those disorders, those mental health problems that have their onset, particularly in the post-pubertal period, they're associated with lifelong disability. We've got to get in those particular years, those things that really go astray between 12 and 16 and then play out between 16 and 25 in major impacts on failure to go on to employment, to education and independent living when we fail to intervene in both young men and young women. The tragedy, of course, is that we have been great in Australia at the epidemiology, at looking at it. So we run these national surveys and we continue to look at it. So we know the age of onset's large in adolescence. 1 in 6 young Australian men and 1 in 3 young Australian women receives any service for those particular areas, and between basically 1997 and 2007, nothing changed. And then we've repeated service systems in 2015, and very little's changed since then. So although we've had a lot of stuff and a lot of discussion, and we are the most mentally health aware nation on earth. I have a great time travelling overseas, talking about my previous work with Beyond Blue and how marvellous we are in the Australian communities, marvellously understanding about actually and sympathetic to those in these particular needs. And then we get to a second sort of discussion, have you actually done anything effective about it? I go, no, we've started another awareness campaign, because that's what we're good at. We're really good at it, and people love it. Politicians love it to come on an awareness campaign, and we Australians love to talk about it. We've got sportsmen, we've got politicians, we've got business people. We actually do have the most sophisticated discourse on earth. Have we changed any of our healthcare system? Not much. You know, and particularly in the state-funded health systems, the local health districts end, hardly anything at all. In the primary care bits, some changes, and now potentially some. But here's the challenge. If we're going to intervene early, and currently we're only hitting 1 out of 6 of the young men and only 1 out of 3 young women, you can see the big gap. And the service needs are mixed in that area. And it's not necessarily touch those things lightly. You know, this is not just had a fight with my boyfriend or arguing with my parents again, or, you know, something's gone slightly wrong on my social kind of media and I'm slightly upset. A lot of this is stuff that is having lifelong impact when failed to be dealt with at the appropriate age. So, you know, there's a kind of issue about the scale and the scope and providing quality services, not just providing any old services, providing quality services that have an impact on functional outcome. One of the good things about the meetings that we have at a very high level with the Prime Minister and the Health Minister at the moment is a kind of interesting dialogue we've been having since 2014 about more experimentation, more testing, more trialling. We don't know exactly what to do, and we certainly don't need to do the same thing in every different place in Australia. There are different communities, there are different sets of needs. And he keeps asking questions about the outcomes. And most of the people I'm associated with, and health services and non-government organisations, they literally do what all health does. They talk about more activity. We'll just do more. And he keeps asking the harder question, if you do more, will it make any difference to the outcome in those particular areas? And that's actually a really, really serious issue. Actually scoping what the needs are in your community, but also when you make these choices that you're making, are they actually changing any of the outcomes? Or are you just doing more with the latest round of funding that actually happens to come along in one form or another in the particular area? The needs issue we continue to know about. And I just want to emphasise, in fact, that the needs are not trivial. So we've had repeated surveys again in young people about the severity of illness, but just on 2 of the things that we do care about, you know, suicidality being one kind of outcome, okay, real physical harm, is common. So self-harm and suicidality, in fact, self-harm and suicidality, particularly amongst young women, appear to be going up in Australia in recent times, and at younger ages, which is particularly kind of worrying. And the second is being absent from school and from education. So the majority of these more severe problems are associated with one or other of those particular complications. So we're not just interested in the symptoms you've got, we do really care that you are keeping children safe from harm during this period. One of the worst things I hear constantly in sort of epidemiology in this area is about half the kids will grow out of it. Go, yeah, if they're alive. You know, we don't say the kids with asthma, you might grow out of it, but do you mind being alive to actually grow out of it, you know? And also not suffer the harm, the morbidity associated with that, and not miss out on the key developmental opportunities, particularly in education and employment. The symptoms may go away, but you may have missed the critical areas of school and post-school education. So the functional outcomes and the protection from harm are some of the key outcome issues that we need to attend to. Now, when the Abbott government, if you remember that government, when they got elected in 2013, there was two big things going on. There'd just been a productivity commission review in aged care. I don't know if you remember that. But the previous minister, Mark Butler, who was the minister for mental health and aged care, we used to say to him, so much better than being the minister for health. When Tanya Purvis said, who wants to be the minister for hospitals and all that kind of stuff? That's terrible. The two really big challenging areas are mental health and ageing. And when he was the minister, he precipitated a productivity commission review in aged care. That we fundamentally need a different business model to run aged care. Just building more aged care facilities and us all paying for them at Commonwealth doesn't meet the aspirations of our current community to grow old in a more healthy fashion and be largely receive services in your home. Got to change the business model. And that's a process which is still going on in Australia and a very difficult one. At the same time, the National Commission that I'm part of, which was set up by Julia Gillard, has as its chairman Alan Fells, the very famous economist and competition commissioner. He goes, can we have a productivity commission review too? Because we just got to change the business model. Mental health is a complicated set of issues of health services, of education, of welfare, of housing, of other areas, and we've got a not very functional state-based LHD system, not very functional welfare systems, poor child support systems, and often poorly integrated, federally funded primary care and other specialist mental health services under Medicare. It doesn't work. It doesn't actually provide the service mix. Now, the Abbott government said, no, you can't have a productivity review, no more reviews. You can do the review yourself. So we did. So in 2014, we delivered, as requested by the minister at that stage, you can remember all the ministers we've had, Peter Dutton, the review on particular services, and put it on the desk of the minister for hopefully release of the Prime Minister at the time, who was Tony Abbott. Now, I just want to say what was at the heart of that in many ways. One is, and people may know, Alan Fells has a daughter with severe schizophrenia, but he'd been very involved in the discussions around the establishment of the National Disability Insurance Scheme as well. You know, mental health is like disability in that sense, that people have complex needs, not simple needs. And their complex needs are often quite different from family to family and place to place. So they don't fit very easy categories. And they don't fit, I'm afraid to say, a lot of what you've seen this evening, the inclusion, exclusion criteria of every service. You know, they're all different and they're complex. But the systems we set up in health, and we love it in health, we're great old Stalinists. We love setting up these central systems that you'll fit in and you'll fit your needs into the next set of services we provide. And no one fits in. Now, at the heart of the disability and National Disability Insurance Scheme is to try and turn things the other way around, to put the person and their family at the centre of the services. And their needs should then determine the service provision, not the service provider to find out whether you fit in with what they do in particular ways. And many people will require, as has been emphasised here in a good way, they may require more than one service. They may require a suite of services. Some of those services may be in health, some may be in crisis support, some may be in social support, certainly as I've mentioned with the Headspace services, support for employment and education, a range of services to achieve the outcomes relative to their needs. So that idea of basically you've got to design a system with the person's needs at the centres, not the providers and the way they do business. That tends to fail. So that implies a new system architecture, which I'll come to specifically, and then actually funding shifts. Now, I think it's fair to say in this audience, a funding shift away from hospitals. At the moment in Australia, we are building more hospital beds in mental health, in both the private and public sector. Give a hospital executive a chance to build a hospital bed, they will. And of course, it's easy to create hysteria around not enough hospital beds. You know, it's easy to do that in any area, no matter how many beds you have. We have national models in Australia, so we have stacks of beds. We don't have the services to keep people out of beds. Or when they've been in beds, to make sure their chance of needing to go back to hospital is reduced. You're always going to need hospital beds. They need to be part of the system. They shouldn't be the dominant part of the system. But we are still, in Australia, both privately and publicly, at our state and through private health insurance, building more beds. Because community demand for mental health is going up. The more you talk about it, the more you recognise it, the more you try to intervene early, the more the community says we want effective services. There's a demand characteristic going on, and so that's really good. People want more services. Trouble is, what do we give them? More beds. The most expensive and least useful part of a whole journey. A necessary part for some, but not the best, in fact, spend. So there's a whole shift sort of issue. At the heart of the new system architecture was, I don't know how many of you have ever sat through those endless, and I can't stand them at all, debates about the federated system we have and the COAG systems that the head of health minister signed off 2 Fridays ago, a new RMAC agreement. We're up to our 5th national mental health plan, an agreement between federal and state ministers about what they can't agree about and what never gets delivered. And what fundamentally is a cost argument, who's going to pay for what. I was just discussing with Magden the danger of this new PHN money is the local LHD stops doing something, says, oh great, Commonwealth's paying for that now, we'll take that away again. You know, which is that terrible sort of cost shifting and shifting of services, as distinct from, and the state end, I've been associated with many Commonwealth initiatives where there's a Canberra-centric kind of view. Somebody designs something in Canberra and then chucks it out in the country and says, you'll all do this. Whether it's our latest suicide prevention program, or it's our latest ATAPS program, or it's our latest drug and alcohol program, with some notion you can just give everyone the same amount around the country and get the same outcome in a particular way, and a very simplistic cookie-cutter kind of approach to the problem. So the system architecture that we were talking about here is not only being person-centred, but to go forget it. The big opportunity, which had been sort of brewing in Canberra and rumbling away for a while, is we've got to get to something that recognises what Australia is. If any of you ever saw Simon Crean's office, when he was the Minister for Regional Development in Australia, he had a map of the 55 functional regions. There aren't states and territories in the Commonwealth. There are 55 approximately functional socio-economic community regions in Australia, by their demography, by their geography, by what the community consists of. They did approximate that terrible thing called Medicare locals previously. It was almost, for 10 seconds, we almost had the maps to match what communities actually were. Of course, new government couldn't tolerate that, had to get rid of that. I mean, the name was appalling, but the maps were close. So now we've ended up with the PHNs, but the good part of that is that it's a Commonwealth getting out of a Woden or Canberra-driven view to actually a regional view. Now, the PHNs, depending on where they are, some odd maps have emerged. If you're lucky, you've ended up with what you've ended up with. A PHN that makes some geographical sense, with a matching state local health district, in this case 1. Now you may not have the easiest one in the country to deal with, but you've got 1. Some others have to deal with 4, and they've got various other things, and some of the geographies don't make a lot of sense. They'll have to run sub-regions to get back to the communities that they actually serve. But you in Northern Sydney have an opportunity. You've got 1 PHN which geographically basically makes sense, and you've got 1 LHD. The idea being, if you could get your act together locally and take the resources that you've got in government, in people, in the community in which you live, you would have the opportunity to make more sensible decisions. Now, you could make the great Australian mistake of the more resourced areas, and I include Northern Sydney in this, is just stack small services in and end up with more competition between 100 new services and not a lot of sense of where a person actually journeys through them and that needs actually met. So you've got the problem of coordination. Other parts of rural and regional Australia have the problem of absence. There's no service. Sometimes having a lot of services, though, and a lot of services who do not have a tradition of collaborating. Lots of LHDs, and most of the ones I've worked with, have no tradition of collaborating with their local primary care-based services in one way or another. And lots of primary care services actually have their own sets of referral pathways not tied in with a lot of the other assets, be they in the private sector, the public sector, the non-government sector. That's often the challenge that one actually faces. So we've said, look, with this big PHN thing's going to happen, we in mental health want to be in it. We want to be in healthcare, we don't understand alone as a funny separate thing, and we want to be part of this new regional thing because regions matter. Non-government organisations matter, community assets matters, working with employment, with education matters. This is not just a health issue, it's a bigger social and community issue. And we need community leadership of that to actually come to play and for decisions to be made locally. So a big opportunity happened this was in the period that was going on between the transition between Prime Minister Abbott and now Prime Minister Turnbull. You guys in mental health, do you want to be in or not? And you want to be in big time. Those PHNs are a bit short of money when we set them up. If we take all the money we've been putting into your national programs off you and hand it over to the PHN in the tune of $380 million a year, that's a big pool of money. We could make a big difference. We could not only shift the architecture, we could start to rearrange it. Now, a lot of people in mental health, my special sector, are not very happy because they were previously running national suicide prevention programs or national drug and alcohol programs or other programs under national NGOs. Headspace is a good example. I was involved in the National Commission. I was previously director of Headspace, about it not really working that well at a regional level. It's a great concept at a primary care level, but it doesn't work on its own. It's got to have pathways out of that entry in. Lots of kids come into Headspace who have more severe problems. Kids who have persistent problems need to move into secondary care services, the sort of thing that Paramount Mission people were discussing. There need to be pathways. They need to be coordinated locally. They need to make sense at a local, regional level as to where those kids actually go if they have ongoing needs. They can't be run out of an office in Melbourne just simply put a Headspace centre over there and don't worry about what's down the street. There has to be a dialogue in these particular sets of areas. That's where we've got to be actually going. So we have pulled $380 million a year out of national mental health, over here to Magda and David, over here to the PHNs. And there's more coming. Now, by the time we got, politics being what it is, we sent this down the line, this review of services, to the health department. They went, "You're kidding, you're joking." We don't really like this. We're much better at giving everyone $10 with a letter from Woden, from the Department of Health, do this. You have this much ATAPS monies for this 6 sessions, for this particular thing, you have $10 for that and $10 for that, and micromanaging all the contracts under the previous divisions of general practice Medicare. Like, it was a bit of a nightmare, I must say, for those who previously ran it. We said, nah, forget that. Take the big money. Okay, the rest of the mental health sector is going to have to work with this. But if the PHN plays fair, if the PHN's a genuine commissioning body, not just the Association of Local GPs or some local consortia that just does a local thing, if they play fair and look at the population needs of where they live, they should be in a position to commission the best local services. And it should involve bringing new service providers in. So the trip from Parramatta here to the North Shore, very glad to see. If they're no good, kick them out again. Get somebody else in the particular kind of way. If the commissioning is fair, you've got the opportunity to bring a better range of services. And you can see immediately what Magda and David have showed is a broader range of services, different kind of levels of mix, not a one-size-fits-all. You need good data to go with that. You need to know what actually happens, particularly in terms of outcome, not just activity. You've got to know from the person end. Now, I don't want to get into the debate about whether a patient's a patient or a user or a client or from the person end, there's just going to be a person in my slide, okay, and a family, does it work for them? That's the big issue. Does it work for them? Does it meet their needs? Are their needs clearly identified? And is a range of services? Now, we're really short on services. We are short on services. The good thing, when Malcolm Turnbull got to launch this in November 2015, and a reporter from the Daily Telegraph was going, "Where's the new money? Show us the money." He said, look, there's no new money in the first instance. We've taken the $380 million off the mental health services. They want to go in this direction because they want it to be regional and to work locally. There'll be new money for those things that demonstrate they can work. And there are also new money for those areas that take a leadership role. And I was just discussing with Magda and David earlier on. Now, I don't express too much views about local stuff because I'm not local. But I do know from travelling around the country that money goes places where there's strong local leadership to say we want to do this new suicide prevention program, we want to do this new academic initiative, we want to do this new youth mental health particular thing, and we will lead that and develop it and evaluate it with partnerships, with groups. There are already significant additional monies being allocated to those areas that take a leadership development, that are positive on these areas. Now, that's actually easier in areas that have capability. If you don't have much, that's very hard to do that. But if you've got a lot of people in other areas and you get organised to do it, you can put up your hand and get more money and then demonstrate that what you're doing is more effective from an outcome point of view and from the experience of service point of view, from the user point of view, from the person and family's point of view. There's a lot of money out there. The review of services we did with the Commonwealth alone in Australia spends almost $10 billion a year, and over half of that is in disability payments. So we pay a lot for being late and ineffective. The whole goal here is to actually reduce the disability side by people having more productive lives and bring more of that money actually into the front end, to the front end loading of that in particular ways, and shifts the cost curve from the disability side and acute care sector side to other sets of sides. And you'll see within that, over time, we don't want to build more hospital beds. We really don't. We actually want to take the opportunities to invest much, much more in primary care, child and adolescent services, etc., as you'll see here, and then what's already happening through the NDIS, significant psychosocial support. So the NDIS is a big and important area. Now, we're lucky in New South Wales. In other states, some really bad things happened under the NDIS, for example in Victoria, where they took money out of mental health services and put it over into NDIS. So they took it out of the clinical bit and put it into the psychosocial support area. So they lost a lot of services. That hasn't happened in New South Wales. So we've also, in addition to what you've heard about this evening, got the NDIS developing. Now, it's really different because the people in the family have the money and they'll decide which services they'll contract, whether you like it or not, which is a really interestingly different economic approach. Health is still dominated by the providers. We still largely give the monies under Medicare, under these programs to the providers. But this is where we're kind of headed in a similar kind of way. So in terms of the outcomes, and just use the youth area now very specifically, we need to be clear about what those outcomes are. I've emphasised numero uno is actually the functional outcome. It's not a K10, it's not a clinical symptom, it's not a depression score, it's not some other silly short-term measure of symptoms. It's actually, as a consequence of what we do more of the kids stay in school, go to school, pursue employment. I happen in my life, I'm very glad to be the father of many children, and my greatest goal is to get them out of my house and for them to live independently. I'd like my own life back at some point. And that depends on them actually being functional in the post-school kind of period. Okay, it's a shared kind of aspiration we all have. From a government point of view, it's more taxpayers and less welfare recipients, etc., etc. But it is what everyone wants in that area. It's not easily achieved by any person, no matter how good they are working on their own. There's a very important monograph by the Institute of Medicine in the United States, about 10 years old now, about quality care in mental health and substance abuse. And it makes the point that single providers are rubbish in achieving good functional outcomes. You've got to have multidisciplinary collaborative teams that have the mix of skills. And they have to work, in fact, across the health and employment, education, welfare sectors to do that. You need highly skilled people, but within team structures. And what we call collaborative in care in Australia, which is largely loose referral between different groups, is not collaborative care. It drives the users of care nuts as they run around with referral pathways to all different bits, trying to get different needs met along the way. It's very inefficient, it's very costly, and often has big gaps. So this issue of getting organised, what you're seeing here this evening is one aspect of that, the use of bigger organisations, like that previously known as United Recovery, some of the other bigger providers in the NGO sector, some consolidation within the health sector on an ongoing basis. Now that doesn't mean simply bigger organisations. We all, as practitioners, need to think about how we work effectively. It also means some very monolithic things, like your average local health district. I don't particularly bag your local health district, but any big local health district that behaves like just the one big monopoly player in an area often isn't very good either. Just because they've got control of the hospital and community assets doesn't mean they're necessarily very responsive to the needs of people in their area. So there's a kind of interesting thing here about large enough organisations working collaboratively and some competition, and some of the purchasing power actually being with those who need the services, like with the NDIS model. So some interesting, really interesting things going to happen in this area. Much is going to happen in chronic disease, I might say more generally. When you've got ongoing complex needs and you need range of providers to get the outcome, you've got to get these sets of things. Now in the youth area, in terms of the other sets of outcomes that are important, I've mentioned the suicidality and self-harm. What most families care about, what most practitioners panic about is, oh my God, you see these young people and they're self-harming, are they going to kill themselves? And we're all surrounded by every day of the week tragedies that occur in these situations. An unfortunate part of my life is spending at times with families who've lost young people to suicide. And a mother in recent times spent time with, the desperate kind of plea, is there anything more that we could have done? Now as a family, I don't believe there's anything more that her family could have ever done. They did everything they possibly could. If she separately said, is there anything more that your system could have done? I would have said yes, stacks. The actual tragedy of the loss of her young daughter was a tragedy of system failure, actually, in truth, and a failure to support that family in a really difficult situation and not provide the level or intensity of supportive care to give that girl a chance of surviving into later life. At a system level, it was poor. At an individual level, that family did everything they possibly could. And that, I think, is the ongoing kind of challenge. It is and remains a big set of issues. There's the comorbidity issues. The drug and alcohol issues are profound. We're just discussing, sometimes we have little gold mines arrive. This one's called the ice money currently. Every politician in the country is terrified about ice. There's a big ice bucket. So it's being handed out to the PHN, the new drug and alcohol monies. Can we do something useful with that? Well, one of the most important things is that if you look at mental health and substance abuse in the adolescent period, about half of our major drug and alcohol problems are preceded by a mental health problem. A kid with anxiety and depression, 12, 13, 14, 15, before, like the 15-year-old with the MMDA recently, before they get into that problem, often has a mental health problem that precedes it. One of my great friends, a woman called Kathleen Merrick-Angus in the United States, she demonstrated about 30 years ago you could prevent about 50% of drug and alcohol abuse by treating anxiety and depression in early adolescence. She just makes the early comments. She's in her mid-60s now. Have we done anything about it anywhere in the world? No. We know what to do. Have we done it? No. We know the epidemiological opportunity because one precedes the other in that area. So one of the goals of what we do in many of these areas is absolutely to reduce and prevent the secondary drug and alcohol abuse, which is associated with so much morbidity itself. In the whole mental health area, in a really good way, there's increasing awareness of how poor mental health precedes a lot of bad physical health. A lot of the cardiovascular disease we see in middle-aged women and a lot of other morbidity we see is preceded by mental health problems. So a focus on mental health problems in young people has a potential to reduce physical health morbidity actually in middle and later life. Big issue for us. At risk, and then a lot of things we do, not just smoking, not just the drugs we use, but a lot of other intrinsic risks are tied up with that. And of course, one of the really interesting things we'd like to be able to do is change the illness course of things like bipolar disorder and eating disorders and schizophrenia. If we intervened earlier, would we see less severe forms? Now, that remains quite controversial about whether we can actually change literally the course of illness. The other four are not controversial. If we did them, we'd see the effect. We just don't do them very effectively. We do very light, on the whole, symptom reduction for short periods, which just don't deliver. They do spend a lot of money. We keep a lot of clinicians employed. How many psychologists say in the local area? 150? A lot of GPs, a lot of psychiatrists in this area, a lot of them employed. A lot of private sorts of facilities. We spend a lot of money, but do we actually get the outcomes? Most of the evidence is no. Too little, ineffective, not great care, not long enough to get the actual outcomes that you're kind of looking at. We need better coordinated care, better targeted at the right time to get the kind of things you're looking at. I'll just skip over the next particular bit. In order to do this better, one is about understanding and developing more personalised care regimes. So you'll rarely hear me talk about specific diagnosis, ultra-high risk to psychosis or emerging mood disorders or this particular thing or whatever. It's about the trajectory the individual kids are on and actually tracking over time what is actually happening to them. Where are they neurodevelopmentally? Where are they socially? Where are they in terms of this development of this complex comorbidity? And actually intervening in that earlier. So that's a big issue for us, working out stages of illness, something I'm personally associated with Pat McGorry. Not saying you've got depression or you've got anxiety, but what stage are you at? You're at an early stage that responds very well to an intervention, or actually at a certain age, are you already at a later stage of illness? You can be 16 and already have a well-developed psychosis, in which case don't muck around in GP land and primary care, get really intensive treatment through your LHD or appropriate treatment now. Don't just go through a whole series of failed services. Like with cancer, if you're 16 and unfortunately got it now, get the very specialised thing now. If you're fortunate enough at an early age to present at a less severe stage of illness, then our opportunity to change potentially the course of that is much greater. So big issues around trajectories and stages. And then of course, unfortunately, what we're talking about is big and common. So the reality is about 50% of Australian adolescents, and I've been involved in twin studies in Queensland now for 25 years, following people prospectively from 12 up to age 30 now. Mental health problems are common in adolescence. So about 50% of young Australians will at some point have a mental health problem. About 25% of those really require care. So about 1 in 4 actually require care. And of those, at least half, so somewhere around 10-15%, if you fail to intervene, will go on to have lifelong morbidity as a consequence. So it's big numbers. So whatever we do, we've also got to do it high quality, personalised and scale. So there are two answers to what we're trying to do. One is these new designated services, headspace type things, to try and create early platforms that encourage young people and really just frankly encourage all of us to think about assisting someone to get care early. Do not wait until they're self-harming, not going to school, got a concurrent drug and alcohol problem. In fact, very interesting, the case is presented by the time the 15-year-old kid is using MDMA, using cannabis daily and whatever else at age 15, let's say he's in stacks of trouble at that point in his education, and a little contact probably isn't going to cut it. It's going to require some serious intervention to change the course of that at that age on an ongoing basis. So there's kind of getting it right. And then what I will mention a little bit on the way here is I'm personally tied up now with the other big opportunity for us is the clinic in the pocket. Is the way in which we may be able to use technologies in the future to engage young people. We've demonstrated trials running of this and currently federal government support to engage people more effectively, particularly young people, in starting to go down the road to access to care and use a lot of e-health interventions, don't require practitioners, to provide a lot of the lighter end and also adjunctive assistance with the more severe end. They don't make clinicians redundant. They make better clinicians more useful, actually, on an ongoing basis. But they're part of the scaling. We now have a potential to do stuff that we didn't have the potential to do 5 to 10 years ago through technology. So the things I'm associated here with Pat McGorry, my great friend and colleague in this, and some other international people, Jan Scott and others, is that we really have these clinical staging models. We're really focused on the idea that we can identify groups of what we call stage 1B, those who've got declining function at risk of big trouble, not yet got the whole kit and caboodle. They need to be our focus. So we can't have simple, and I must say, this is not David's fault, but some of those models that come from the Commonwealth, they're a bit simple. Mild, moderate, severe, blah, 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 blah. As if you just stay there, as if there's a big population group here just called mild, whatever. It's not true. No. There's groups that are moving constantly, and young people that are getting it right from the start as to where they are, independent of age, and get the stage right. And we are investigating neurobiologically and clinically, what do we do? And there is this issue then of matching the dose and the nature of the intervention with the stage of illness, not a simple severity kind of thing, but where they're literally at in their personal trajectory. So there's some issues developing here about how clinical care will be enhanced. The good point of what you showed is you'll need a range of services to respond to that. You'll need a lot of stuff that we would argue that's e-health based to do a lot of stuff easily for a lot of people that's very engaging and quite effective. But as it gets more complicated, the role of clinicians and the complexity goes up. Right? There's nothing simple about general practice. There's nothing simple about this primary care stuff. It's complex. By the time you get your hands on it, it's complex. By the time most Headspace's services get their hands on it, it's already complex. Yet we're treating it as if it's kind of light. We're treating it as if they had a fight with their boyfriend or a difficult day at school, which actually isn't changing the outcome. That's where we've got to really be focused. We're part of a wide set of international services who are reviewing these particular things. And of course, the establishment of Headspace around the country has been part of that. I just want to dwell on the quality bit. So I'm part of a larger NHMRC Centre of Research Excellence about quality. It ain't simple. But that's also working with a range of practitioners. It doesn't mean that everybody has to do everything. But the physical health bits, and I really like the Headspace presentation in terms of the nurse role of that, the identification of the physical health bits, the clear emphasis here this evening on pick up the substance abuse bit importantly along the way, in addition to the other sets of issues that are relevant. So we're involved in looking at these kind of stages of illness by various pathophysiological profiles and various sets of neurobiologies, and basically trying to get in to a better characterisation. Now, the interesting thing, if you work in this area, and I know people work with young people, is most of the kids I see at this age, 17, 18, with these complex disorders, diagnostically, I don't know what's wrong with them. You know, I reckon I'm pretty experienced in the area, but I don't really know. I can't really say at that point where they're going. What I can say is they're in stacks of trouble. And we need to actually work with them and their family to find the best optimal treatment, to manage the risk, change the course in terms of psychosocial function. A proportion will stay put there, but a proportion will deteriorate, will get worse, like in other staged illnesses, like in cancer and inflammatory diseases. And if they get worse, we need to go with them, trying to minimise the disability and the consequences, even though their actual illness is still getting worse, while we're trying to work out better kind of treatments. Most services we run are at late stages for a few people with developed disorders, so there's this shifting to this earlier but quite challenging phase. So I think I can say this in the room. We need a bunch of mature doctors and other people who can cope with the fact that sometimes people have bad things. And they can be with them during those particular periods. They're not in a panic over everything, but they're actually serious partners in the partners of care of people who may be at risk of going on to develop more serious things and having lifelong impacts in that particular area. The area has been filled traditionally with lots of youth services, lots of people who are friendly with young people, but not necessarily so good about the fact that those things can go really bad and they're complex. And some of it does require serious medical intervention along with serious psychological intervention and social support, and can actually be with the complexity of the chronic illnesses of young people, which is what a lot of these mental health problems are. So we've been tied up in a lot of these services, and I just simply want to say, in our evaluation of things like Headspace services, Currently, there's nothing really early about them. 25% of the kids are already got disability support, got major mental health problems, already out of school and support. But we're headed in the right direction. But now is the challenge to get it right in the youth area and in others. And it's good to see today the kind of emphasis that you've put on the youth area. I just want to say, concurrently, what you'll see come out research-wise is more and more about what's actually going on underneath, brain-wise, physiologically, body clocks, circadian systems, other aspects of physical health. So I'm tied up in a whole lot of other research in the brain, in the body, about all the other stuff going on. The bottom line of all that in those particular services is the extent to which we need more sophisticated people working with more sophisticated treatment paradigms, both experimental and new. Now, we can come up with all the new treatments in the world. If we cannot deliver them at the right stage of illness and in a persistent, multimodal way, multidisciplinary way, we will not achieve the outcomes that we're interested in. And now what we do is we've handed the responsibility over to you. Well, it was the case. You know, a lot of people in the PHN world and other people world think something's going to arrive from Canberra with the answer. I'm here to tell you there is no answer, right? The whole philosophy, you know that, you've worked that out already, right? The whole philosophy is we've chucked you the cash. And as I say, a lot of people in the mental health world are not too happy about that. They think you're going to fail. Some of you are aware that the Prime Minister, through the Health Minister, well, the Health Minister did it, not really the Prime Minister, set up a review committee recently to look at what the PHNs are doing. So the National Commission I'm on, several people, our CEO and several others are on that, to look at the PHNs and sort of check you're not wasting our money on an ongoing basis. Now, personally, I think that wasn't a necessary thing to do, but it was to keep the mental health sector happy for a while. You know, that we weren't just throwing the baby out with the bathwater, that we weren't just pulling out of more specialised sets of services and key issues and throwing it into some non-specific primary care GP thing that was just going to waste the money. So some people who know me very well would know that fundamentally I'm a rather anxious and irritable person. This is a period of much anxiety in my life, right? Because we've done something in theory. In theory, it makes sense in Australia to be organised regionally, to have local partnerships decide what the demography, the opportunities are here, what you really need in Northern Sydney, who can really take those leadership roles. Work with the communities to say what the community needs actually are. Work with experienced practitioners to figure it out. But to do that, you've got to kind of let go of the central control. And that's both a state thing and a thing. We hope, the model is designed to have co-investment in the same region from the state-funded services. And the lever for change, in fact, though, is the PHN monies. It's a small part of the total, but it's the one where there is discretion, actually. And we would hope there's a spirit of willingness, a much greater spirit of willingness to engage with the community to make that opportunity. So I am going around to various PHN meetings at the moment going, good luck. We really hope you succeed. We're looking from this national level to, well, what we're actually desperately looking for is a few places to succeed.
We'll be there.
We know, well, I'm going to say, we know what's failed. We are experts in what's failed. I went to I tell the story of having often in my sort of national roles, you get to go to these international things. And I went to a World Economic Forum thing about Australian mental health, blah, blah, blah. And we have all these great policies and we do all these particular things and we talk about, in a sense, we are very progressive. And this German woman who was at the thing, she goes, yeah, I know you, you're Australian. Great policies, hopeless implementation. I went, yep, that's us. You obviously know us extremely well. She said, I've looked for 25 years at all your great policies and plans and tried to work out whether they made any difference. She wasn't actually waiting for my commentary. She just said, you've obviously failed. I said, yes, well, we have largely. We know that what we've previously done has not worked. Increasingly, the community that expects it to be better tells us it doesn't work. Nearly all the data we have is of increased expenditure with little impact on the actual outcome. So we have leapt into this great experiment to say, look, regionality, you know, the Gippsland far north of Queensland, you know, Northern Sydney is not the same. They're different places. They've got different sets of possibilities. They need different sets of arrangements. They need strong cooperation. They need strong local leadership. Then just finding my role with the National Commission is really tied up with data. We need evidence, and that evidence to get used locally, not to be put in a warehouse in Canberra or sent to the ABS or some other nonsense place where it's never used. That data to be actually used to inform local decision making. So your PHN is engaged, it's just completed some mental health service mapping, some population sets of issues. Of all the great things that you've heard this evening, what I want to hear in a year's time is, what did they do? You know, did they do anything different? Or they just picked up another 10 kids here, another 10 kids there, and maybe they're the same 5 kids, and maybe they weren't. And did the outcome change? Were they a significant improvement over the previous thing? Did they really work with the other services? Did the GPs really buy in? Did the LHD actually do anything different? Did the big group in the middle, that youth severe bunch of kids, who's really the ones, which is most of the kids who come to care in Australia are already youth severe, they're not youth light, they're in trouble in big ways. Are they actually achieving different sets of outcomes? Because the spirit of local cooperation, of working with kids and with families in genuine partnerships is different. So I really hope you succeed. And I'm quite enthused, if you like, that at least the local leadership's got it straight about the task. I hope Canberra or no one else actually interferes too much in what you're doing. But the other side of the coin, if I could strongly encourage the GPs in the room and the others to actually participate. You know, what you're hearing, what you're finding out, whether any of these new services actually do anything different, or it's just a plethora of new things that just compete. They've all got 10 kids here and 10 kids there and another office in Chatswood and one over there and whatever, but you can't see any difference. That's got to go back into the mix. And all those services you love in, Parramatta Mission, love you, but if you're no good, get rid of them. There's a better one from Wollongong, you know, and whatever else. You know, if the LHD's not playing ball, got to have that discussion. There's got to be some hard discussions. If Headspace is not really doing what it's supposed to do, need to know. You know, that's the bit, and that requires a willingness to participate. Now, I know it can be pretty frustrating with the amount of reform that we have in Australia and the number of cycles we've been through. Trust me, in the mental health world, we've been through many. So, you know, for many of us, this is like last throw of the dice. This is our best attempt, in theory, to come up with something that might work through local leadership, through local empowerment. So I wish you well, and I'm desperate to come back in 12 months and find out, did it make any difference?
Thank you so much. So just before we start, so I'm Lynelle Hales. I'm the CEO of the Sydney North Primary Health Network, and on behalf of the PHN and certainly of the board, a huge thank you to Professor Hicki for coming tonight. I mean, it's wonderful to actually get that big picture oversight, but also some real inspirational and challenging thoughts for us as we go on this journey together. But I thought, does anyone want to ask any questions while we've got? Oh wow, lots of people.
I like your diagnosis, the person's in real trouble. That's a good way. However, you've mentioned the need to pick people up early. And one of the most important groups is missing from this. School counsellors and junior school teachers. These are people who pick up the behaviour disorders and talk to parents, and parents say, oh, they'll grow out of it. And we're missing from that thing. The slide you showed about absence and behaviour problems, I think it had a number on it, number 17. We're missing those people in the team. Autism is picked up too late in many people. ADHD, I pick up often in adults as depression. We need to get in earlier, and I think it behoves the PHN to look at the role and the education of teachers and school counsellors and augmenting that service. It's fairly important. With regard to your website, please can you make it a little more user-friendly so we can find where the forms are that we want to download, and can you make those forms editable?
Yes.
Okay, thank you.
So I'm glad you raised the autism. The child area here, we've focused tonight, and most of the Australian focus at the moment is actually on the youth kind of bit. I am tied up with a whole lot of issues at the moment about further investment in the child area. So autism, attention deficit, educational difficulties. So one of the things that you may not be aware, but the change, and I'm part of a Prime Minister task force with Simon Birmingham on transforming early childhood care to early childhood education. And it's actually about picking up the earliest signs of failures of cognitive development and emotional development in those particular periods. So there's a whole lot of work to be done. That will largely be done at that bit in the early childhood care sector, trainings and issues in that area. And then, of course, in the primary school sector, there's an enormous amount of work as well. So there's a recognition that what you said is exactly true. Of course, in the health sector, we've not been good partners with the education sector. So there's a tremendous amount of work to be done in those areas. The most encouraging bit is the amount the federal government's going to spend in the early childhood area and to transform the language from early childhood care. It's not child just taking care of kids. It's the opportunity for enhanced education, school readiness, and part of that is the detection of these developmental difficulties at an early age, where the opportunity for intervention, for effective intervention, is higher than if you wait another 10 years.
Thank you, Professor Hicki. I'm a health professional in the community. I'm a registered nurse, but I'm also parent of 2 young adults that have had lots of diagnoses with ADHD, etc. So I agree completely that it's a really scary place to be. Are there any, this is more of a personal inquiry, are there any clinical trials in place for autoimmune neuropsychiatric disorders? Because I've got, we've been through the system with my daughter particularly, with Sydenham's career and rheumatic fever, and whenever she gets a big problem with her inflammation from strep throat teeters rising, she gets hugely anxious, but then she developed a movement disorder, which I actually think explains a lot of different things.
When I talked about new treatments coming down the road, one of the areas of most interesting novel therapies is in the neuroimmune therapies, and it's the adolescent period associated. So nearly most of the drugs that are really effective in the adolescent period have strong immunomodulatory. So there's a whole lot of issues going on in that area. There are a whole lot of, some personally associated with trials at St Vincent's and at Westmead in those particular sets of areas. The identification and characterisation of kids in that area, really challenging, but it is one of the emergent areas where we just haven't been focused enough on the individual things that are going on. So we have these big categories you just get dumped in that just say you've got a major depressive disorder or something, or some other psychotic disorder, and they miss the complex morbidity of it. So we reckon about, there's various estimates, but 10 to 20% of the kids who've got more severe and persistent disorders probably have an underlying autoimmune type diathesis.
Yeah, is there any way that GPs...
Happy to. There's no simple referral, but I'm happy to tell you how to do it. There are specialised clinics. There are some serious specialised clinics associated with St Vincent's and Westmead.
Look, I just want to make a comment in our area health service that most of the psychiatrists are not in this team that we're talking about, and have a very private practice model, and we have terrible trouble getting anybody to see them without a very high fee attached.
You know, you have more psychiatrists per head of population.
But well, are there any other psychiatrists here tonight, for example, apart from you? Because I think that's a really big gap in how we approach mental health in general, and especially youth mental health.
Yes. So all of our national services, I often joke with Pat McGorry, there's him, he goes up and does headspace services in Coffs Harbour, and myself and my partner Elizabeth, there's about 5 of us in the country actually servicing that whole thing. Right, so we get this terrible mismatch between area of need, because what you need is the complexity in this area is high. You've got to have people who say, like myself and Pat and Liz, my partner, it's okay, we don't know what's wrong with them, but that doesn't matter. Rather than, but a lot of people are actually avoidant of the area, and the great majority of our psychiatric services are tied up in individual practice in standalone private Medicare supported services in Australia. The least effective model to achieve a good outcome. So that's a national problem with the mismatch between our funding systems, our funding incentives, and the way people practice. So we have some big skill deficits. We have a lack of general practitioners actually working in the area, and we have a lack of psychiatrists working in the area. Who are not saying you have to spend your whole life as part of these teams or whatever, but effectively working in those team-like frameworks. It's a big issue. And I think David has said it 2 or 3 times, I've noticed. A challenge for the area, despite the number you have per head of population, is to actually get effective population coverage from what you've got. Yeah.
Thank you very much for your talk, Professor Hicki. Just a comment really. Point 5, prevention of mental illness.
Yeah.
I really like, but the trouble that you have here is we know how to prevent chronic diseases with cardiovascular disease, diabetes, etc., with lifestyle measures. We often don't know exactly what the cause of the mental health disorders are. And if we don't actually know exactly what's causing them, it's hard to know how to prevent them. I've got some thoughts on that, which I'm happy to talk to you later. But is there some good quality research that looks to determine the cause of mental illness? I know it's multifactorial. I realise.
Well, there are some. It's like other things. It's like there are some specifics. Now, I think it's slightly unfair to area. It's like, we've got some of our equivalents of like smoking, right? And some of those are like childhood sexual abuse, right? You just got to do everything you can to reduce the prevalence of that particular thing in the community because of its lifelong consequences, which is just like you do everything you can to reduce smoking. We'll still have chronic disease, but it makes a big difference. So there are some single risk factor type issues that are actually things. And in fact, if you look at social attitudes towards childhood sexual abuse and other things going on, we are clearly in a transformative period. First, we're going to beat up all the organisations and churches. Then we'll get on to the really hard issue that most of it occurs in families. There's some really challenging sets of issues. You've seen the, other sets of issues. It still remains one of the big issues for us that kids that come out of same-sex attracted as adolescents are at high risk of suicide and suicidal behaviour. Despite the incredibly tolerant society we live in, it's still not easy to actually come out during that critical developmental period. There are real challenges. So there are some very specific things we need to do certain things about. The secondary prevention of two things. The secondary prevention of drug and alcohol abuse by dealing with mental health problems actually is. Now, whether you call that a primary preventive or a secondary preventive thing is a bit of an argument, but you've got one thing preventing one other major thing, and the two together makes a bad chronic illness. But it's a very important. Now, the other way around is a pathway issue. You do more to reduce drug and alcohol use, you reduce the secondary mental health problems. So things like the ice issue and other things are really serious issues for us. Alcohol use in Australia, and unfortunately we have some things, you may or may not be aware, but actually cannabis use and binge drinking are actually going down. It's not all hopeless in terms of some of the risk factor modification that's actually going on. So there's no simple immunisation strategy, but there is some pretty effective risk factor modification going on at the population level. At the individual level, early intervention's the thing. No, we can't say that just like with immunisation, there's a one-to-one between doing the thing and getting an individual outcome. But the moment the thing starts to emerge, then in terms of its consequence, the likelihood that it will become a chronic disease, just like for the rest of us, please stent my arteries or whatever before I get heart failure, Like, do the effective intervention first, there's a fair chance I'll maintain a functional kind of outcome. Fail to do it, I'll probably end up with a chronic disease. So in terms of chronic disease prevention, early intervention is terribly important. So we still have ways to go, and part of this is this answer about specific pathways, because we are dealing with complex pathophysiological things. So there's a whole set of autoimmune diseases, under-recognised pathways, my personal favourite, body clocks, circadian disorders. There's a whole bunch of specific stuff going on. So if we have this discussion in 10 years' time, 15 years' time, there'll be a whole bunch of new specific illness categories because of what's going on neurobiology-wise. But unless we fix the service problems about when and what we do, we'll be in the same boat. Time to go home, I think.
Thank you so much for that.